So what is a definitive therapy? Now, the treatment of childhood ALL has evolved considerably since the past 6 decades, like I told you. Initially, all children used to get the same treatment. But now, since we know that many children are surviving this disease, it's very important that we give them a good quality of life. So that's the reason now there is something called a risk stratification or a risk-based treatment. What is the risk we are talking about? The risk is the risk of relapse. So if you have a child with a high risk of relapse, I'll obviously treat them more aggressively. Vis-a-vis a child with a low risk of relapse, I may come down on the therapy. So what are the factors that help me to do this risk-based treatment? They can be divided into patient-based factors, disease-based factors, and very, very importantly, the response to treatment. So what are the patient-based factors? Patient-based factors are if your age of the child is less than 1 year, where we call it an infant ALL, or more than 10 years, where we call it an adolescence, then these children do not have very good outcomes as much as those in between the 1 to 10 year age group. WBC counted diagnosis more than 50,000 is again a very poor risk factor or a high risk factor. Gender, it has been observed from various studies that boys do worse than girls. This is because, some people have postulated that it's because of the testicular involvement of the leukemia in boys. So it could be a possibility. Or CNS involvement or testicular involvement at diagnosis, again, a poor prognostic factor. If you have an underlying genetic syndrome like a Down syndrome, then definitely, your odds of doing well are lesser. So what are the disease-based factors? Disease-based factors, we discussed immunophenotype, B cell versus T cell. So if you see the differentiation of the hematopoietic stem cell, it divides into a myeloid stem cell and a lymphoid stem cell. So the lymphoid stem cell divides into a lymphoblast, which gives rise to the B, T, and the NK cell. Now, it is very important whether we have the cancer arising from the B lymphoblast or the T lymphoblast, because the B cell lineage do much better than the T cell lineage. And then we have the cytogenetics. So what are the cytogenetics? Like I was telling you previously, it is very important to understand what change in the DNA of the lymphoblast caused them to start replicating uncontrollably and cause them to, become immature as well. So for you, the most important good risk ones, good risk means those children will behave better, they will respond to therapy better, are the hyperdiploid ALLs, okay, those who have chromosome numbers more than 50, and the ETV6 RUNX1 mutated ALL. So these two are very, very good risk cytogenetics. When we come to the bad risk cytogenetics, we have several ones, and the most important ones are the Philadelphia chromosome, the IAMP, the internal amplification of 21 chromosome, and the haploid. All these are low hypodiploid haploid. That means where the chromosome number is less than 40. These are all very poor risk prognostic factors. So obviously the good risk ones can do with reduction of therapy, and the poor risk ones, so the high risk ones, need intensification of therapy. Lastly, more and more important of late is given to the response to treatment. So we determine something called MRD in the bone marrow. MRD stands for measurable residual disease. So at the end of the first month of therapy, we want to see how much percentage of lymphoblasts are remaining. And this gives us very good idea as to how the patient is going to respond. Some groups also do day 7 and day 14 bone marrow responses. Then we see something called the response to steroids. So whenever we have a circulating blast and we start them on steroids, I'll come to the treatment later. When we start them on steroids, we need to see the disappearance of blasts by day 8. If they disappear by day 8, we say it's very, very good response to steroids. And again, these children do much better. Of course, the last point, persistent leukemia at the end of induction, or we call it as induction failure, is a very, very poor or a high risk factor. Now coming to the treatment. So the treatment of ALL is done in 4 phases. The first phase is called remission induction. It lasts for about 4 weeks. And the goal of this therapy is to induce a complete remission in the bone marrow. That means to reduce the amount of blasts from whatever 90% to 0%, so that the bone marrow can start functioning normally. Almost 95% of the patients achieve this particular time point. That means 95% of them respond very well to remission induction. What are the drugs used in remission induction? The most important drugs are vincristine, steroids, asparaginase, and some groups may or may not use anthracyclines. But these three drugs are extremely important in remission induction therapy. Certain groups do not give anthracyclines. By anthracyclines, I mean doxorubicin or daunorubicin, because they have the potential of causing cardiac toxicity in the long term. So people use it only for those who are high risk of relapse. Corticosteroid, they may either choose to use prednisolone or dexamethasone. Although dexamethasone has improved CNS penetration and gives better results, but it causes a lot of toxicity. So the overall outcomes for between prednisolone and dexamethasone are almost the same. And asparagine depletion. So asparagine is an amino acid. It's an essential amino acid that our body can make. But the lymphoblasts cannot synthesize the asparagine. They are dependent upon extracellular asparagine to work. So what asparagine depletion, PEG asparaginase or conventional asparaginase does it depletes the asparagine in the extracellular compartment. It brings it down to 0. So once the asparagine is depleted, the lymphoblasts cannot synthesize proteins because they don't have that amino acids and they end up dying. After remission induction, we go to something called consolidation. So consolidation, what is the aim of it? It aims to eradicate the submicroscopic residual disease. So just because I have achieved remission does not mean I have eradicated the entire leukemic clone. There will still be one or two, even if there is one or two cells that are left behind, the disease can come back. So it is these aims to eradicate the submicroscopic disease until complete remission is obtained. It lasts for 6 to 9 months, differs upon various cooperative groups. And obviously children with high risk disease receive longer and more intensive therapies. So basically it is a combination of several drugs which are not used in remission induction. So it could include mercaptopurine, thioguanine, methotrexate, cyclophosphamide, etoposide, cytarabine in various combinations. So that why do we use combination therapy in ALL? To maximize the synergy. So if you have one anti-metabolite, for example, methotrexate, then you have one cell cycle inhibitor, which damages the cell, like cytarabine, which incorporates into the DNA and damages the cell. So they're both going to hit the cell at two different points. So this is called synergistic effect, and also to minimize drug resistance. So if I give only one particular drug, so obviously nature is much ahead of us and these cells may develop resistance. This is about the consolidation. Then maintenance is the final and the longest stage of treatment in ALL. It lasts for about 2 years. Certain groups like the UK group give 3 years for boys and 2 years to girls, because boys have a little worse outcome than girls. It's much less intensive. So it basically involves outpatient therapy with oral medication. But it's very important to be adherent to the medicines, because even 1 day's loss of medicine can actually increase the risk of relapse by 30-fold. So prolonged maintenance therapy has demonstrated to lower the risk of relapse. It involves anti-metabolite therapy with methotrexate and mercaptopurine, and both are anti-metabolites. So one, methotrexate targets your folic acid pathway and mercaptopurine targets the purine pathway, synthesis pathway. So you're hitting the cell from two sides. And some regimens also include monthly vincristine and steroids, but it has not shown to have that much of a improvement in survival as compared to no vincristine and steroids. Lastly, we have CNS directed therapy. So when they started treating ALL way back in 1960s, they saw that although they were achieving a remission, many of these children were coming back with the disease in the CNS, because your CNS and your testis serves as a sanctuary site. What is meant by a sanctuary site? A sanctuary site is, so you have the blood-brain barrier. The brain is a privileged site. So your blood-brain barrier or your blood testicular barrier does not let the normal chemotherapeutic agents enter into that space, right? So that's the reason why many of these children, these cells used to escape and wait in the CNS, and when the environment is suitable, that means when there were no drugs, they used to come back in the systemic circulation. So now this is directed both with clinical CNS disease. That means if I do a CSF and find those blast cells in my cerebrospinal fluid, or if I don't, it is called prophylactic. Why is prophylactic given? For subclinical disease, and specific therapy is targeted. So what can be the specific therapy? One is manipulating the systemic chemotherapy. For example, methotrexate doses or cytarabine doses given in much high concentration can penetrate the blood-brain barrier, the blood-testicular barrier, and target those cells. Or you can give a direct intrathecal therapy, that is a direct injection into the cerebrospinal fluid space, where the drug goes and targets those cells that have been hiding. Lastly, the other way to target them is by using cranial radiation, that is to radiate the brain. This is less commonly used now. Definitely, it's out of the protocols in most of the developed countries, and in India also it is phasing out because cranial radiation causes a lot of long-term side effects. So this is a capsule, the treatment of ALL. So induction phase is to induce remission immediately. Vincristine, steroid, probably anthracyclines, and of course asparaginase, that is not mentioned here, that is extremely important. Consolidation phase eliminates subresidual microscopic disease cells. So based on the patient's risk factor, you can use cyclophosphamide, cytarabine, 6-MP or thioguanine, 6 to 9 months long. And maintenance phase is to decrease the risk of relapse post-treatment, involves 6-MP and methotrexate, and sometimes pulse doses of steroids and vincristine, is 2 to 3 years long. So a minority of patients, like I said, 5% patients, so 3 to 5% patients realistically may have induction failure. That means after induction, they don't go into remission. And induction failure is one of the worst prognostic factors. And most of them require a allogenic bone marrow transplant to induce remission and to bring about the graft versus leukemia effect. So coming back to our first case, this is an 11-year-old girl who came to us just with low-grade fever and some petechia on the legs and had a very, very high WBC count. So WBC count is definitely more than 50,000. So if you had to risk stratify her, this girl has age more than 10 years, which is bad for her. T-cell immunophenotype, which is bad for her. The WBC count is more than 50,000. It's again very bad for her. But she had a good prednisolone response. So when we saw the response to assessment, she had a good prednisolone response. That means all those 380,000 blasts disappeared by day 8 from the peripheral blood. And when we assessed her bone marrow at the end of consolidation, she had gone into a MRD negative remission. That means there were no microscopic cells that were detectable. And presently she's doing well due to start maintenance. So thank you so much. I will end.